natural opening of the eye controls how much light enters. Under normal conditions, it adjusts automatically. But in some clinical scenarios, it can become abnormally small, a condition called miosis, or abnormally large, known as mydriasis. So in this video, I'll take you step by step through three key questions. Which drugs cause miosis and which cause mydriasis? How can you remember this information for the long term? What symptoms accompany miosis and mydriasis? But first, why do they happen? Pupil size is controlled by a balance between the sympathetic and parasympathetic nervous systems. When the parasympathetic system is stimulated, the sphincter pupillae muscle, controlled by the oculomotor nerve, cranial nerve 3, via the Edinger-Westphal nucleus, contracts, causing pupillary constriction. This is miosis. Conversely, when the sympathetic system dominates, the dilator pupillae muscle contracts, causing pupil dilation, or mydriasis. This process originates in the hypothalamus, travels down the spinal cord, and descends via the superior cervical ganglion, either enhancing sympathetic stimulation or blocking parasympathetic influence. Primary pupil abnormalities, miosis and mydriasis, are often linked to specific drug classes. Miosis occurs in poisonings related to cholinergics, opiates, organophosphates, phenothiazines, and sedatives. A useful mnemonic to remember these causes is COPS. C, cholinergics, pilocarpine, clonidine. O, opiates, morphine, heroin, fentanyl, or organophosphate poisoning. P, phenothiazines, chlorpromazine, pontine hemorrhage. S, sedatives, benzodiazepines, barbiturates. On the other hand, mydriasis occurs with sympathomimetic toxicity, anticholinergic poisoning, and withdrawal from opioids or benzodiazepines. A simple mnemonic to remember these causes is SAWS, sympathomimetics, cocaine, amphetamines, ephedrine. A, anticholinergics, atropine, scopolamine, antihistamines, TCAs. W, withdrawal, opioids, benzodiazepines. Other causes of pupillary dilation include hallucinogens, LSD, ecstasy, PCP, and carbon monoxide poisoning. Identifying the cause of miosis or mydriasis is not enough. You must also assess associated clinical presentations, as they can help narrow down the diagnosis. Clinical red flags for miosis: pupillary constriction. Pinpoint pupils plus respiratory depression points to an opioid overdose. This classic triad suggests opioid toxicity and requires immediate naloxone administration. Miosis plus bradycardia plus excessive secretions, sludge, points to organophosphate poisoning. Think insecticide or nerve agent exposure. Sludge stands for salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis. This condition requires atropine and pralidoxime. Bilateral pinpoint pupils plus coma points to brainstem lesion, e.g. pontine hemorrhage. This is a neurological emergency requiring immediate imaging and evaluation. Clinical red flags for mydriasis: pupillary dilation. Mydriasis plus tachycardia plus hyperthermia points to sympathomimetic toxicity, seen in cocaine, amphetamine, or ephedrine toxicity. These patients often present with agitation, hypertension, and seizures. Mydriasis plus dry skin plus urinary retention points to anticholinergic toxicity, a hallmark of atropine overdose or tricyclic antidepressant toxicity. Patients may also have flushed skin, hallucinations, and absent bowel sounds. Unilateral dilated fixed pupil plus altered consciousness points to brain herniation. This is a neurosurgical emergency indicating uncal herniation, often due to increased intracranial pressure, ICP. It requires urgent imaging and intervention. If you found this breakdown helpful, don't forget to like, share, and subscribe for more videos. Also, let me know in the comments what topics you'd like to see next.